All right, well, we're going to get started because we have a lot to cover today, even though it only seems like two topics. The operational changes in Medicare is quite a bit of material. So we're going to go ahead and get started, and then we'll look at the Medicaid program. So there's been a lot of changes to Medicare since it was incepted in 1965. The first of those changes came with fee limitations for doctors. Um, at the same time, there were per diem limits set on hospital reimbursements, so like per day. And then another change came in 1997. I think it was made previously, but it was supposed to be temporary, and then they made it permanent. But it required that Part B enrollees' premiums cover 1/4 of the costs. Another change that came in 1983 was the way that doctors can charge higher fees than the allowed fees. There was a shift from per services payments to per admission payments for hospitals, something called the prospective payment system. And there was also a shift to a new physician compensation system called resource-based relative value in 1992. So we're going to look at each of these in detail today. So first of all, we'll talk about limitations on fees. So early on in the program, doctors were paid based on what were called prevailing fees. And the prevailing fee was basically just definitionally defined as it was defined as the 75th percentile of all fees. And so basically what happened is if a doctor's fees exceeded that percentile, then Medicare would only pay the prevailing fee. And so this basically affected the top 25% of doctors in terms of their fees. At the time, this was the only cap. This was the only limitation on fees at the time. And then came the Nixon administration in 1971. And I don't know if you guys know about the history of the economy at that time, but basically we were facing a period of stagflation. So maybe you've heard of that. So prices were really going up a lot, and the economy was in a recession. And so to combat increasing prices, they placed a freeze on prices economy-wide. And they were meant to be temporary, but they ended up being permanent for two industries, and those were the petroleum industry and the healthcare industry. And basically, the limitation was how quickly doctors could increase their fees. So it wasn't that they couldn't increase them; it just there was limitations on how much they could increase them. And the rate at which they could be increased was determined by a cost index that was entirely representative of a typical physician firm's business. Later, another limitation that was part of the Omnibus Deficit Reduction Act of where fees were frozen and lasted until 1987. And then at that point, some doctors could increase their fees, still faced stiff limitations. And the difference came between a distinction whether the doctor chose to be a quote unquote participating physician or not. So if you were a participating physician, you could increase your fees. And if you were not a participating physician, then there were stricter limitations on fee increases. Oh, shoot, I'm not recording. Oh, yes, I'm cool. So this brought about something called assignment of benefits. And this is kind of an older feature of Medicare. And so basically, Medicare, the way it works is it pays up to 80% of the costs up to an allowable fee. And so if the allowed fee is, for example, $80 and the physician charges more, then Medicare only pays 80% of that $80, which is $64. But if a physician charges a fee that's less than the allowed fee, say $50, then Medicare would only pay 80% of that, right? $40. So that's how this assignment of benefits worked under the original system. And this is going to have an economic impact on fee limitations, right? The two are going to sort of coincidentally affect behavior. And so under this original system, assignment of benefits, doctors, since they're only being paid 80% or sometimes less if their fee was higher than the allowed fee, they had the option of billing the deficit to the patient. And then patients would have to submit the bill to Medicare for reimbursement. The problem is that some patients would end up not paying at all, and so it introduced a financial risk to the physician. And they could avoid it by taking this thing called assignment of benefits. And it basically allowed them to collect the full 80%, and then they only had to try to collect the remaining 20% from the patient. So it helped to reduce their financial risk. So why does this matter? And particularly, what is the relationship to these fee limitations that started to crop up starting in the early 70s? Well, it matters because if they elected, this is an optional thing, right? So they're not required to take the assignment of benefits. It was an election, so they could choose to take it or not. And if they chose to take it, they might be forced essentially to take a lower fee, but they would have a better chance of collecting. So the risk would be reduced, right? But I guess the expected payout might be lower because the fee would be lower. Or they could choose to not take the assignment of benefits and they could charge more, but there's a higher risk of being unable to collect the payments. And so from an incentive standpoint, doctors are going to take this assignment of benefit if their fee is below or at the allowed fee, since that wouldn't really negatively affect them, or if there was a high risk of default from patients. So it seems like there's a pretty good incentive set up for doctors to be incentivized to take this assignment of benefits. And then in 1983, they introduced this concept of participating physicians. And this fundamentally changed how the whole assignment of benefits worked. So previously, it was done on a case-by-case basis, right? So a doctor would have a patient, and for that particular patient, they would decide whether they wanted to take the assignment of benefits or not. But given the change in terms of participating physicians, given the creation of this concept, if you were a participating physician, you basically elected to automatically take the assignment of benefits, while non-participating physicians still made the election on a case-by-case basis. And as it turned out, the incentives were good and strong, and so a majority of physicians elected to be participating physicians. And what this allowed was for them to increase their fees more rapidly than non-participating physicians. And obviously the incentive worked. Participation jumped from around 50% to almost 70% when the change was instituted. And today that rate has reached 90%. So the incentives worked. It got physicians to become participating physicians. And over time, this has been increasingly the norm for physicians to take the assignments of benefits. And in fact, in recent years, almost all of claims are paid through this system, 98%. All right, so next we're going to talk about something called the prospective payment system. And this has to do with hospitals. So originally, hospitals had been paid based on services provided. So the more services they provided, the more money they got as a reimbursement. But this same legislation in 1983 also changed how hospitals were paid. The approach was phased in over 4 years as to not shock the system too much. And what it did is it started paying hospitals on a per case basis or a per patient basis rather than a per service basis. So again, previously they had paid hospitals based on the services provided. Whoops, this was a duplicate. I guess I added something when I duplicated this. So as it began to pay on a per case basis, it basically meant that for hospitals and admitting doctors, they now had a fixed budget per patient with which they had to operate. And so since it's a fixed price, we can kind of look at this like a price-taking firm with a horizontal demand curve, right? A perfectly elastic demand curve. They can sell as much hospital care as they want at that fixed price, right? And so what this means ultimately is that the hospital is going to choose to provide a quantity of services where this horizontal demand curve is tangent to their average cost curve. And since it's horizontal, right, that means that that tangency must take place at the minimum of average cost. And so basically it's essentially trying to force efficiency on the hospital. So from some standpoint, that makes sense, right? We want hospitals being more efficient, but there might be some perverse incentives involved. So where do these prices come from that the hospital receives? It comes from something called diagnosis-related groups, or DRGs. And they basically assign each patient that they admit to one of these groups. And the payments vary by region and hospital type, particularly whether it's a teaching hospital or non-teaching hospital. And so if we think about this from the hospital's point of view, since the price per admission is fixed, it receives the same revenue regardless of what services it provides, how many, and how long the patient stays in the hospital. The latest change to this system came in 2005, where a new Medicare severity DRG was created that relates these groups to the complication, the complications involved with the illness. So this was an attempt to try to provide a little bit more flexibility, basically, to the hospital. Provide them with more funding if the illness is more complicated, essentially. So if we compare this to the old model, doctors on the medical staff could basically provide whatever services that they saw fit, right? But with these DRGs, if they continued to behave in this way, the hospital would ultimately start to lose money. So this is really one of the first problems with this setup, is that every individual doctor has very little incentive to control costs on their own. So this is a situation that's real similar to prisoners' dilemmas, right? Particularly the issue discussed by Newhouse that we saw when we were learning about physician firms, right? The physician firm has a group of physicians, and it would benefit everyone in the group to reduce costs, but no one has an individual incentive to do that. So in order for the hospital to not go under, right, the medical staff has to find some way to motivate doctors within the group to try to lower costs. Otherwise, the hospital might go out of business. So there's some ways that hospitals responded to this incentive change. And perhaps the most obvious change is to try to decrease the length of stay for patients, right? Because every day that a patient stays in the hospital costs the hospital more money, and they only have a fixed budget to work with per patient. And so this is probably the easiest adjustment to make because length of stay is relatively easy to monitor, and guidelines on length of stay are relatively easy to develop and interpret. And furthermore, any doctors that sort of deviate from the guidelines can relatively easily come under pressure of other members of the medical staff to try to lower costs. Now, these efforts would essentially be pointless if doctors did not have any discretion over the length of stay of a patient. And furthermore, the length of stay is widely varied across regions. So really the only option is for the medical staff to find some way to coordinate doctors' behaviors. And then if they can do that, then the length of stay should fall in response to these DRG incentives. And overall, the change to DRG under the prospective payment system was actually really successful in reducing length of stay. And we can see that in this next graph here. So here we're seeing total days of care. Okay, so this is one measure of length of stay. And as we can see that after the implementation of the PPS, length of stay in terms of total days of care dropped drastically, right? It dropped precipitously and continued to decrease into 2005. Another way we can look at it is length of stay, average length of stay, as well as discharge rate, which is the rate at which hospitals are discharged. And we see the same sort of story, although it's not as clear. It appears that length of stay was already declining. Now, part of that might be because of technological progress, right? As technology improves, people don't have to stay in the hospital as long. But we do see that as soon as the PPS was introduced, it dropped faster. It dropped even faster. And aside from this slight uptick here, it continued to decline until 2005. And we can also look at the discharge rate. So the discharge rate had been increasing, which means that patients are being discharged quicker, which generally translates into a shorter length of stay. Is that right? Discharge rate. Oh, yeah. Okay. Sorry. I'm a little bit backwards on my interpretation of this. So the discharge rate is telling us how many patients are discharged per 1,000 enrollees. So it had been increasing. And as soon as the PPS came into effect, it dropped dramatically. And then it started to uptick again in the early 90s. And I think we're going to talk about that in a second here. So let's just move forward. So it's kind of interesting that the discharge rates responded too, because the incentive was really targeted at reducing length of stay. So what's going on here? Well, as it turns out, there was an interesting interaction going on between newly available technology and the DRG incentive. So the prospective payment system came about at the same time that outpatient surgery was first becoming feasible, right? So surgery that does not require hospitalization. And probably the most notable example of this occurred in cataract surgery, right, which has to do with vision. And this is particularly something that older people have to get. And so there's actually two features of cataract surgery that kind of created a so-called perfect storm for hospitals. The first feature is that this surgery is not typically an emergency procedure. It's something that doesn't need to be done right away. The procedure can be delayed if the physician feels that's necessary. And so that's one issue. And then the other issue is that the procedure is very safe and simple. And so basically, half of the spike in hospital discharges before the PPS came about was coming from a burst of in-hospital lens procedures, these cataract surgeries. But then after the PPS, the system shifted abruptly into ambulatory settings where this very safe and simple procedure could be done either outside of the hospital or within the hospital, but it didn't require overnight stays, which is what we would consider a hospitalization, is when people stay overnight. And so this effect on discharges was basically coming from these companion peer review organizations. And they were charged with monitoring overly long length of stays, trying to make sure people weren't staying in the hospital too long. And so these pros became the mechanism that allowed the medical staff to coordinate doctors' responses to the PPS incentives. And the biggest effect took place in ophthalmology. So looking at the difference pre and post PPS, 85% of these procedures were in hospital in 1980 compared to 25% by 1985, just 2 years after PPS was implemented. So quite a dramatic decrease. And another interesting thing happened as a result of the PPS. It appears that ophthalmologists advised patients to have the procedure done before the rules took place. And so this led to partially led to the burst in the hospital discharges that we saw, as well as the precipitous decline in 1984. And this is rational behavior, even if the surgical fee is the same, regardless of whether it's inpatient or outpatient. Now, the same thing took place in other procedures as well. And Russell, 1989, discussed 40 procedures that had been identified as potential candidates for a shift towards ambulatory care, just like these ophthalmology procedures. And sure enough, in-hospital admission rates for these procedures rose in the period prior to the PPS, and then fell 15% starting in 1984 following the introduction of the PPS. So the same thing that happened with cataract surgery also happened in these other 40 procedures. Now, this also brings up the issue of potential substitutability, right? Substitution can also help to lower the length of stay. So one of those substitutions are skilled nursing facilities, or SNFs. And so the use of these facilities increased by 5.2%, 12.8%, and 5% respectively in the first 3 years of the PPS. Another substitution is home healthcare. And this, in fact, increased by even more during the same period. Additionally, Medicare added a temporary benefit for hospice care, which is another substitute. And hospice care is basically a low technology alternative to dying in the ICU, right? You can die at home comfortably in your bed without having to be in the ICU in the hospital. And these services increased at a high rate as well since the benefit was introduced. And just to get an idea of how popular this benefit was, only 31 hospices were certified for Medicare in 1984, 1 year after the PPS, and now there are over 3,400. So this benefit seemed to work, right? And so this growth in hospice care has almost definitely decreased both hospital days as well as the average length of stay. And it's mainly because hospice care provides two useful substitutes. So the first is ambulatory surgery and hospitalization in hospice care. So all of these substitutions also helped to decrease the length of stay. Now, one particularly concerning issue here is that if you're giving doctors a fixed fee per patient, then that would seem like that would provide the incentive for them to reduce the quality of care, right? And so there might be a negative or adverse effect on patients' health. And so there were many opponents that made this argument, and they were predicting very disastrous health outcomes for these patients. But fortunately, there was a commission that was part of the PPS called the Prospective Payment Assessment Commission, or PROPAC, and it monitored outcomes within the PPS system. And it was intentionally designed to try to avert any decreases in care or quality. So how can we look at this and analyze it? Well, we can use some common indications of poor outcomes. One of those is readmission rates. So this is when people are discharged from the hospital and they have to be readmitted because they were basically discharged too early. And usually it's readmission within the first 30 days. That's the standard measure of poor outcomes. And what the commission found was that the rate was relatively the same before and after the PPS. So it appears that there actually was no increase in poor outcomes as predicted by the system's opponents. And furthermore, the rate of readmission had actually been increasing up until the point of the PPS being introduced, and then it began to taper off after, which is basically indicating that outcomes did not get worse. In fact, they maybe even improved a little bit. Whoops, that's the wrong. I should say sicker and quicker. Another measure of poor outcomes is mortality rates. And again, this is typically measured within the first 30 days of discharge. So if the patient dies within 30 days of being discharged, that's not a good sign, right? But this comparison is not as straightforward because there's basically two forces that are conflicting with each other that have altered mortality rates over time. So of course, over time, technology has improved, and that has increased the average age of the Medicare population. But despite the complication, it's still perhaps useful to look at. And during the first years of the PPS, mortality outcomes didn't really change. And a separate analysis showed the same result. So Kahn et al. Found that in 3 of 5 high mortality disease categories, mortality rates actually declined, while average length of stay also fell by 24%. The other 2 categories remained unchanged. And this was all occurring while patient discharges were happening after a shorter length of stay. So they were basically being discharged in less stable condition, but despite that, it did not increase mortality. So that's good, right? The major concerns of a decrease in quality of care seemed not to have come to fruition. So then the question becomes, well, what are the consequences of this for hospitals, right? And almost unambiguously, it negatively affected hospitals, right? And to see why, all we have to do is look at their revenues and their margins. So their net revenue margins had been steadily climbing from 1970 to 1983, with a brief dip in that Nixon price control region in the early 70s. But their margins had been increasing, and so they were becoming more profitable. And then with the PPS, that trend reversed starting in 1984, and the margins continued to decline until 1991 when they started to recover once again. So one possible response that hospitals might have to combat these declining margins is to decrease the intensity of treatment, both through a decrease in length of stay as well as perhaps other changes. And in fact, Hodgkin and McGuire showed that intensity did in fact fall significantly. Now the downward pressure on these hospital margins, like I said, turned around in 1991, and they returned to profitability between 1991 and 1997. And the change came from improved efficiency, which is exactly what the PPS was one of the things it was trying to achieve, right? And so this is great, right? After not, it took about 6 or 7 years, but after that period of time, that initial introduction of the PPS, and after adjustments were made, so this is really like a long-term concept, right? You can almost think of it in terms of sticky prices and sticky wages, but over the long term, hospitals were able to adjust and become profitable again, and they did so by becoming more efficient. And Congress took notice of this, right? So they saw, oh, hey, these hospitals are making a good amount of money again, and we'd like to balance the budget. And so part of the Balanced Budget Act led to basically a recapturing of these profits. So the Congress went in and basically said, hey, it's nice that you're making that money, let's take it from you. And this ultimately drove their margins back into the red, where they were no longer profitable. Now, this kind of brings up one issue that we haven't talked about yet, and that's the issue that hospitals might try to induce demand. Since they're facing a perfectly elastic demand curve, essentially, they can sell as much services as they want, or I guess hospital stays, patient care, as they want at that fixed price. And so it makes sense that they might try to increase quantity by inducing demand. But in fact, the opposite occurred. Occupancy rates actually fell. And admissions followed the same pattern as length of stay. There was a decline in admissions. All right, so we can see that here. Hospital occupancy starting in 1980 here. So you can see that, sure enough, shortly after the PPS was introduced, occupancy rates started to decline, although they kind of stabilized relatively quickly. They didn't continue to decline, but they did decline over that period. Now, something else we'll talk about in a second is that another way to try to save money is to reduce costs in terms of employment. And in fact, that did happen. So this FTE stands for full-time equivalents. And this is a rate, so percent changes that we're looking at here. So we do see that after the PPS was introduced, there was a significant reduction in employment, both in total full-time equivalents as well as inpatient full-time equivalents. Although let's see, I guess, oh wait, there was actually an increase following the PPS, which is interesting. I'm trying to understand why that would be true. Maybe I have it in the slides here. Another way we can look at admissions is the number of beds that a hospital has, right? So the number of beds, the number of hospitals that had fewer than 50 beds declined. And in fact, all of these, so this is basically the size of the hospital, right? This is telling us the size of the hospital. And all hospitals got smaller in terms of their admissions, right? So we do see a reduction in the number of people being admitted to hospitals. So that's, that covers hospitals. It worked pretty well. It got them to be more efficient. It got them to reduce length of stay. It also got them to admit fewer patients. So it was successful in saving money. So then the question is, well, can we do the same thing with physicians, right? If it's successful with hospitals, why not try to do this with physicians? And in fact, Congress already had this idea in mind when they created the PPS initially. They decided to commission a study on the effects of other types of medical care. And this was called the Physician Payment Review Commission. And it was charged with providing recommendations about how to perhaps alter physician pay to try to achieve the same results, right? Increases in efficiency and those sorts of things. And the first of these studies came from Harvard in late 1988. And they developed something called relative they developed a relative value system called the resource-based relative value system. And it was a pretty complex task to develop this. And what they did is they used a standard coding system that physicians still use, called the Current Procedural Terminology, or CPT for short. And it describes roughly about 7,000 different procedures. Well, that's a lot of procedures to study, so they chose to study only 372 of them, and then they extrapolated the results to the other procedures. Now, this idea came from California, actually. So California had something similar called the relative value system. And basically the idea of these systems is to try to pay equal pay for equal work. And so that's kind of interesting because it's equal pay regardless of whether you're like a neurosurgeon or just a general practitioner. And so now that this has been fully implemented since 1996, there have been several studies to show its impact. And so as we would expect, since this is providing equal pay for equal work, general practitioners were predicted to benefit most from this system, since they were typically earning less than the average physician. But then surgery intensive specialists suffered. So it's kind of averaging out everybody's payments, essentially. And in that way, it would bring up general practitioners' payments and bring down specialists' payments. So that's great, but there's still some unanswered questions that are really important and interesting that we want to think about. What has happened to the mix of medical interventions in the short run as well as in the long run? And then what changes have taken place in the patterns of specialty training, right? Because if specialists are essentially made worse off by this, then we might expect that people are going to choose to become specialists less frequently. And the answers to these questions are going to depend in a considerable part on private insurance. And that's because the adoption of payment schemes like Medicare would reinforce the effects of Medicare's actions. So remember, we talked about how private insurance started to adopt some of Medicare's payment schemes, and doing so would help reinforce the actions of Medicare. Now, these DRGs that are for hospitals worked for three important reasons. The first is that the episode is well-defined and has a well-defined beginning and end, right? The beginning is the hospital admission, the end is the hospital discharge, very clear cut and dry. Another key reason is that there's only one economic agent delivering the care, and that's the hospital. The third important reason is that the DRG system can account for an important part of the overall variation in hospital costs. Okay, so how does this translate over to physicians? Well, in ambulatory care, it's very difficult in many cases to clearly define an episode. And this is particularly true with patients that have chronic illnesses, right? They're constantly coming to the doctor. How do you define the beginning and end of that, right? And so within the physician context, it seems like this episode-based PPS system is not feasible. Although it may still be possible for inpatient care. Because again, inpatient care, they're admitted, that's the beginning, they're discharged, that's the end, pretty well defined, right? Then there's this issue of multiple economic agents. So a lot of ambulatory care involves more than one physician. So there's not just one economic agent involved with the care of the patient. There's many economic agents. And so the only feasible way for a DRG system to work with physicians in this setting is to have one physician payment for each illness. Now, how would this possibly be? How could this be possible, particularly in areas where multiple physicians might be needed? Well, we could imagine that maybe the system would work where there's sort of a primary physician that is the primary contractor, and that any other physicians that are needed for the care of the patients would be essentially subcontractors. So that one physician collects all the payments and then has to make payments to these subcontractors out of their own payment. So this might work, and in fact, it might be the only legally feasible way to do this, is give the patient autonomy over who is the primary contractor. So even though it might be feasible, this seems kind of complicated and difficult to implement. All right, and then the last issue is potential within group cost heterogeneity, right? Variation in cost within a group. Now, DRGs work well in hospital settings because the DRG system doesn't leave the hospital. It's entirely contained within the hospital group. And so this allows the system to confront any variability in costs within the hospital. So it can reduce heterogeneity in costs, reduce the variability. But then the question is, can this be done with physicians? And essentially, the absence of a clear time frame in which the group can be defined is the most essential source of trouble. If you can't clearly define the time frame of these group of treatments, then how do you start to control the costs and the variability of costs? It becomes very difficult, right? So these are really major problems with trying to implement DRGs with physicians. So there might be some alternatives to DRGs, right? One of those is time-based payments, also known as capitation, which we've talked about before, right? So this is a payment on a per-year capitation system, right? And it doesn't matter; it's regardless of the condition of the patient. So while this might be an alternative, it does introduce substantial financial risk for the physician. And in an insurance setting, the risk is not that hard to handle. All you have to do is create a large pool, right? Enroll tens of thousands of patients, and then there's no issue. But a physician can only really enroll maybe a few hundred patients at most, so they can't spread that risk out as well as an insurance company could. So given this risk, the only possibility for a solution is to create some sort of risk-sharing arrangement, potentially with some sort of stop-loss provision. And we've seen these types of provisions already in Medicare Part A, right? Within the hospital setting. We need something that's similar for physicians in order for this setup to be successful. But such a formulation has not been created within the Medicare system. And proposals typically speak of capitation payments to insurance companies rather to physicians. So while this might be an alternative, it seems like the issues regarding risk have prevented it from becoming a real solution. Another potential solution is global payment caps. And this actually has roots in private insurance. So some insurance plans have these overall limits. What they do is they contract with physicians to hold back a portion of the fees, perhaps 20%. And if the physician's overall spending exceeds target amounts, the deficit is taken out before holdback funds are returned to the physician. And so these caps come with both advantages as well as disadvantages. So the advantage is that they will guarantee the amount of total expenditure for the paying entity. So there's very little risk for the paying entity because they know with pretty much almost 100% certainty what the costs will be. But at the same time, they might also guarantee that overall spending, the limit on overall spending is exceeded, and it might happen in ways that actually penalize doctors that are trying to make the system work. And that's a real problem, right? if the doctors that are trying to make the system work are penalized, they're going to stop trying. And again, this is very similar to the prisoner's dilemma. And if you want to look at that in more detail, you can refer to box 12.1. So the physician payment problem in this situation is really only very slightly different from the prisoner's dilemma. So think about it this way, right? Suppose that a group of doctors agrees to cooperate and keep costs down. But then, right, this is the cooperate strategy, right? Don't snitch on your partner. But then, of course, one doctor discovers that there's actually a better strategy, and that's to charge as quickly as possible. If others also adopt the same strategy, they will trigger this holdback, and every physician's payment will be reduced. Okay, so pretty much just like the prisoner's dilemma. Okay, so that covers all of the changes that have taken place, or at least the proposed changes. We've looked at some proposed changes as well. So those are all the changes that have taken place since Medicare's inception. Now we're going to look at Medicaid, right? Oh, and I will mention that I skipped one section of this this change section. I skipped the Balanced Budget Act of 1997, so you don't have to worry about any of that material. I did it for the sake of, brevity. But anyway, so now let's look at Medicaid, okay? So Medicaid was introduced at the same time as Medicare in 1965, but it operates a little bit differently. So the way that it operates is with state-federal partnerships that involve cost sharing, which is very much unlike Medicare. Okay, Medicare is a purely federal system. States are not involved in any way, and there's not any cost sharing between states and the federal government. And it's designed primarily for low-income people, and it hinges on the federal poverty line multiplier that is established by the Bureau of the Census for families of different sizes. And unlike Medicare, it covers almost all types of healthcare, including a lot of what Medicare does not cover, with the most important difference being in terms of long-term care or nursing home care. Medicare has limitations on nursing care, while Medicaid does not have limitations. And so because of these state partnerships, Medicaid actually is different from state to state. And it differs in terms of who is eligible, what services are covered, and how providers are paid. So this is variable from state to state. Now, the reimbursement aspect of the program is very important, particularly because there have been budget control efforts by many states, and it has caused them to offer very low fees for Medicaid procedures. And this has the effect of limiting the range of options for people that are on Medicaid. And we'll talk about those limitations in a second. So first of all, let's think about who is covered, who is eligible for Medicaid. First of all, anyone that's eligible for income assistance is also eligible for Medicaid. So that's the first sort of hurdle. On top of that, the federal government has created mandatory eligibility. So there's some eligibility rules that states have to adhere to. And here's a summary of those. So the first is anyone who meets the requirement for the Aid to Families with Dependent Children program, which came into effect in 1996, is also eligible for Medicaid. Anyone that has fewer than 6 children and whose family's income is more than 133% of the federal poverty line is also eligible for Medicaid. Obstetric services for pregnant women with family income of more than 133% of the federal poverty line are eligible for Medicaid. Anyone who is a recipient of supplemental security income in most states, but not all. Adoption and foster care recipients under Title VI of the Social Security Act are eligible for Medicaid. Specially protected groups are eligible for Medicaid, particularly those who lose their cash assistance due to earnings from work or from increased Social Security benefits, but who may keep Medicaid for a period of time. And then the last group is children who are under the age of 19, born after September 30th, 1983, with family income less than the federal poverty line. So these are the minimum requirements for all states. But then states can elect different eligibility requirements that are more generous than this if they like. Okay, so like I said, many states actually have more generous definitions of poverty than the minimum requirement. So states can choose a percentage of FPL that determines whether you're eligible or not. So on the low end, that percentage is 133% of FPL. So just barely over the federal poverty line, while states on the upper end go as high as 300% of the FPL. So these are the more generous states, obviously. These are the less generous states. And about 20% of the entire population is enrolled on Medicaid at any given point, while state by state enrollment ranges from 11% up to almost 30%. All right, so we've covered who is covered. Now let's look at what is covered and how it is covered. So like I said earlier, Medicaid provides coverage for essentially all medical care services. And in fact, most states provide more than the minimum requirement. Some services involve cost sharing with some limitation. Those limitations are that cost sharing is not allowed for pregnant women, children under 18, patients in a hospital or nursing home who are expected to contribute most of their income to institutional care, as well as individuals using emergency and family planning services. So those people are not subject to cost sharing. All right, the next question is, what pays for all of this, right? The funding comes from the federal medical assistance percentage. That's the primary source of funding. And the program basically looks at each state's per capita income and compares it with the national average. By law, the rate can't go below 50% of per capita income, and it cannot go higher than 83% of per capita income. In recent years, 12 states received only 50%, while the average was about 60%, and the highest was about 77%. So because states can choose how generous they are, they typically decide the level of generosity based on income and price effects. So states that have a higher per capita income tend to have more generous programs, but they also face higher prices. Okay, so there's an income effect and a price effect. And most studies have found that the income effect is actually the predominant effect, outweighing the price effect. And so states that have higher per capita income tend to have more generous enrollment rules. And because of that, they tend to have a higher percentage of the population that is eligible, since it's a more generous rule. Um, so then what are the effects on access, right? Because we talked just a second ago about how some of these limitations might reduce access for patients, right? So keep in mind that this is mainly for poor people, people that are in poverty. And the American Hospital Association looked at the ratio of reimbursement to hospital costs. So they looked at Medicare, they looked at private insurance, and they looked at Medicaid. And what they found was that Medicare reimburses at a rate that's just under 100%, so pretty much almost 100%, while private insurance reimburses at about 125%, which I'm not sure where that's coming from. Why is the insurance company paying more than 100%? I don't know, but that's what they found. While Medicaid reimburses at only 90%. So Medicaid, it seems to be doing a pretty poor job of paying healthcare providers. Certainly worse than Medicare and private insurance. And physician compensation is even worse. Decker in 2007 showed that Medicaid rates are only about 65% of Medicare rates, and that's pretty bad, right? For hospitals, it was 90%. Physicians, it's 65. So it's even worse for physicians. She also showed that these rates affect the provision of care. Only about 40% of doctors accept Medicaid patients in their practices. And this is a limitation for patients, right? It makes it harder for Medicaid patients to find a doctor, since only 40% of them will accept them as a patient. She also showed that Medicaid's compensation generosity affected the length of the visit in the direction that we would expect, right? So the closer that Medicaid came to Medicare compensation, the longer the visit was. The further, the lower it was compared to Medicare, the shorter the visit became. So, and that makes sense, right? That's a pretty straightforward result. If doctors are getting paid less, they're going to spend less time with patients. Right? So all of this limits the access of low-income persons. It's harder to find physicians, and even if they do find a physician, they're not going to spend as much time with the physician. And in fact, these limitations on access are so prevalent that Medicaid has actually built in an extra payment called the disproportionate share payment. And these are payments to physicians that are treating an unusually large number of Medicaid patients. And so these payments are channeled to public hospitals or hospitals treating at a specific rate above the state average. And without these payments, compensation rates would be even lower than they are. But this was a way to combat this limitation, this access limitation issue. And I think the effect was successful. It got more physicians and hospitals to accept Medicaid patients, and it may have even lengthened the duration of a physician visit. All right, the last issue is how does Medicaid pay for long-term care? So Medicaid is actually a substantial funding source for long-term care. It covers nearly half of all long-term care expenses. And this is about twice the national average of long-term care enrollment, and it accounts for more than 1/3 of all Medicaid spending. So that's a huge fraction of Medicaid spending. Now, interestingly, most of the support actually goes to women. And that's mainly because there's two reasons for that. The first is that women typically outlive men by an average of 5 years. And on top of that, women on average marry men that are older, which means that they are going to be living alone for somewhere between 5 and 7 years on average. And living alone is one of the main determinants of a person choosing to move into a long-term care facility. And so 3/4 of all nursing home residents are female. And I've seen this. I've gone to visit my grandmother. I didn't realize it at the time, but I was like, wow, there's a lot of ladies here. What's going on? And it makes sense now that that I thought about this, right? That makes so much sense. So, so that's pretty interesting. Now the long-term care program has both an income test as well as an asset test for eligibility. So they look at the person's income as well as the assets that they have. And so this is mainly because retired people live on retirement income, which is usually a fixed income, and they typically also have a store of assets. House, they typically own a house and may have other assets like securities and stocks and bonds and those sorts of things. And so what the program does is, well, first, let me say that because of these rules, particularly the rule on assets, it provides an incentive for these people to try to dispose of their assets so that they can become eligible for the program. And so to combat that sort of perverse incentive, Medicaid created a look back rule. And so they actually look back in time and use the patient's history of assets to determine whether they're eligible, rather than looking at their current assets. And this period of time was a 3-year look back period. And that was actually expanded to 5 years as a result of the Deficit Reduction Act of 2005. Okay, that's it. That's the chapter. Wow, we got through that fast. I guess I could have covered the Balanced Budget Act after all, but oh well. Now you don't have to worry about it. All right, do y'all have any questions about anything we covered today? All right, cool. So just a few things I want to say. First of all, I really appreciate you guys. You guys were great. Thanks for participating and showing up to class most of the time. And let's see, what else am I trying to say here? Yeah, I enjoyed teaching this class. It was a lot of fun. As far as your third exam and your final, I decided that I'm going to not include this chapter on the third exam. So the third exam will only cover chapters 9, 10, and 11. Chapter 12 will be on the final. Also, remember that the final is optional. I know I'm a little bit behind on getting your exam 2 grades back to you. I'm going to wrap that up today so that you have that and you can make an informed decision about whether you want to take the final or not. I will also have all of your homeworks graded so that you can make a decision regarding whether you want to take the final. And that should be done by tomorrow. And then on top of that, I've also, I don't know if I mentioned this before or not, but I've also decided to make the homework for this chapter optional as well. And so basically, if you do the homework for this chapter, it'll basically drop your lowest homework grade. Okay. So if you missed any homeworks, this optional homework can replace it. Let's see, is there anything else I need to mention? I think that's about it. The questions for the homework, I already have it posted. I think it was questions 2, 4, and 8. Let me double check that. Stop sharing this for a sec. Yeah, 2, 4, and 8. Cool. And that'll be due May 10th. So that if you do it, I have time to grade it and give you feedback before you take the final. All right, I think that's all I have to say. So if y'all don't have any questions, I enjoyed teaching you. It was great having you. Oh, by the way, are either of you seniors that are graduating? You are? Okay. I just wanted to know because I have to have your grades in earlier than everybody else's. So good to know. All right, cool. Well, yeah, if y'all don't have any questions, maybe I'll see you around. I don't know. But if not, have a good life and good luck on your assignments, your remaining assignments. Bye.
Thank you.
All right, bye.